So the last thing that we wanted to talk about, we've talked about phase one, which is the diagnostic tests, and we talked about phase three, which is surgical treatment. We highlighted laser ablation and the neurostimulation devices. These are the new technologies. But depending on your type of seizures and what they look like and what we find in that phase one diagnostic test, there might be an intermediate step, phase two, where we do direct brain recordings. And depending on where you are in the process, this may be a big hesitation for some people considering epilepsy surgery. Of course, it may not be necessary for everyone, but if it is, there are some advancements here too that we can talk about. So the traditional way that this was done for decades in the United States was with what are called subdural grids. And this is a big open surgery, traditional open surgery, where we have to put these electrodes, these flat grids of electrodes on the surface of the brain to more precisely map seizures and brain function than we can do when we put the electrodes or the EEG on your scalp. So this is basically EEG that's recording directly from the brain. You can see we can identify little hot spots where the seizures are coming from. We can also record where different functions in the brain are coming from. And so this was a helpful technology for many years, but it was a big deterrent for many people to want to undergo epilepsy surgery because you had to commit to this big surgery up front without even knowing for sure what we were going to find. The other problem is that the brain is not a flat structure. It's not just the surface that we see on the outside, but the brain is actually a three-dimensional structure. And all these little folds of the brain that are deep on the inside, they can also be part of where the seizures are coming from. And so those surface electrodes, those subdural grids, were sitting somewhere out here on the outside of the brain, and they weren't able to sample from these deep brain structures. The newer approach, at least here in the United States, it's been used in Europe for many, many years. But the newer approach has been to implant wires through the skin and through the bone directly into the brain to sample all these deep structures. And these are very, very tiny wires that we're implanting through the scalp and through the bone. And the way that we're able to do this safely is with relying on a lot of computer navigation and robotics again. And so that's the reason that it wasn't done for many years in the United States, but now with the advent of the imaging planning software and the computer navigation and robotic surgical assistance, this has become more widely accepted and used in the United States. And so we can actually plan each one of these wires. We can see where it's going through all the different views of the brain, avoid the blood vessels to really minimize chance of any kind of bleeding or complication. And then we go to the operating room. We have our CT scanner again in the operating room that gives us that GPS system for the brain. And then that is specific for you. And then in particular, here's where the robot is really helpful because we have to put in several of these wires and plan the trajectories ahead of time. The robot can very efficiently line up each one of those trajectories very precisely. And again, it's us doing the surgery. The robot is there to guide us with the navigation. And then similar to the old approach, you then will spend 1 to 2 weeks with us in the hospital. You can see here from the picture on the left, this is still an invasive procedure. It's still a scary, big undertaking for many people, but it is much less invasive than the old way of doing things. We can often spare significant parts of the hair by having you braid your hair ahead of time, so we only have to minimally shave around where the wires are going in. And you can see each one of these wires is actually very, very tiny. They're about 1 millimeter in diameter. The white parts that you see here are just the little plastic caps that are outside the head. But the wires that are actually going into the brain are quite tiny. And then from there, you stay with us for 1 to 2 weeks in the hospital for monitoring so that we can record the seizures and see where in the brain that they're coming from. So what is the recovery like from this robot-assisted stereo EEG, and that's what we call it, is stereo EEG, and we kind of think of that as the way that stereo surround is different from a single speaker. We're listening to the brain from multiple different angles in this approach. So stereo EEG. Recovery, we mentioned it's 1 to 2 weeks in the hospital, not because it takes you that long to recover from the surgery. You're recovered by the next day. But the 1 to 2 weeks in the hospital is for us to monitor the seizures. You go home the same or the next day once we've recorded enough seizures from the brain. And then it's about 1 to 2 weeks of recovery at home. And then you come back for the treatment surgery in 3 to 6 weeks. And the treatment surgery is now informed by what we've found from actually recording directly from the brain. What are the risks of robot-assisted stereo EEG? So risks of serious bleeding are about 1%. And that's a bleed that would require us to actually evacuate the bleed, or that would be symptomatic. And so this is fortunately quite a rare event these days, and that's because we're able to really plan accurately with our image guidance and our robotic assistance. The rate of infection is also less than 1%, and we have not had any deaths in our experience of doing this for about a decade.